Well, good evening, distinguished colleagues. Welcome to our second module. My name is Dr. Onyemeshet, and I welcome every one of us to today's clinical meeting by the Endocrine Pharmacist Group. I recognize everyone here. I recognize the presence of the National ESCO of Clinical Pharmacists in Nigeria. I also recognize the ESCO and the Dex officer of the Endocrine Pharmacist Group. And our speaker today is Dr. Adenike Atanda. Dr. Atanda is a board-certified ambulatory care clinical pharmacist and a certified diabetes care and education specialist with practice experience in geriatric and adult medicine. She's an assistant professor in. Hello, can you hear me? Hello?
Yes, we can hear you.
Okay, let me start again. Certified and a certified diabetes care and education specialist with geriatric experience in geriatric care and adult medicine. She's an assistant professor at the HAC College of Pharmacy. She currently serves as the program director of the HAC/HAC Health Program. She has experience in self-management of diabetes and support program. She's practicing and her interest in practicing this providing so in the next few seconds we shall have Dr. Atanda on the as she presents her lecture for today.
Good evening, everybody. Can you all hear me? All right. Good evening, everyone. Thank you so much for the invitation to come and talk to this esteemed group of my colleagues, clinical pharmacists, about the management of obesity as it comes to the treatment of diabetes, specifically type 2 diabetes. So I have a presentation I wanted to share on the topic, and I'll be sharing my slides shortly. If you could please feel free to any comments or questions in the chat feature of Zoom. I would love to be able to answer your questions within the time we have together. And then also as a reminder to please make sure that your microphones are muted so that the recording can be clear for the information shared this evening. Can you all see my screen?
Yes, we can.
Okay, great. Let me make sure there we go. So as a reminder, again, we'll be talking about the management of obesity in patients with diabetes. Please feel free to leave any questions you have in the chat. I have no conflicts of interest to disclose, and we'll be discussing about risk factors for weight gain in patients with diabetes, also describing complications that are associated with weight gain in patients who have diabetes, and then lastly, talking about the medications or pharmacotherapy options that we have to use for the management of obesity in this particular population. So as we all know, diabetes is really a metabolic disorder that is characterized by hyperglycemia due to either complete insulin production that has been seized, or we have insulin resistance in type 2 diabetes. We have several categories with the majority of our patients having type 2 diabetes, about 90% of our patients that we see. And then about 10% or less will have type 1 diabetes, which we know is the autoimmune disorder that causes complete destruction of the beta cells in the pancreas and causes insulin production to be halted or seized. When it comes to the regulation of glucose homeostasis, there are several players, not only in terms of hormones like insulin and glucagon, but also thinking about the organs that are involved. So diabetes is a very complex disease state. It not only affects the blood sugars, as we see in our clinical presentation, but we can also have problems with cardiovascular disease states, renal disease states, thinking about hepatic dysfunction as well. And so it's really important for us to have several modalities that we use to treat and manage patients with diabetes, and also to address any complications that arise. So I wanted to spend most of my presentation really talking about weight management as it relates to obesity and also in patients with type 2 diabetes. So to go over the classifications again, when we talk about obesity, we're looking at a body mass index of usually 30 or higher in our patients. And so obesity can be classified into three main classes, depending on how severe the weight classification is or weight problem is. And so for patients who have type 2 diabetes, we also know that obesity is a contributor to insulin resistance and also one of the big risk factors for cardiovascular disease development. And it's something that we want to pay very close attention to ensure that we can optimize patient care and life longevity for these patients. And then for patients who do not have diabetes or have not been diagnosed with diabetes, we also know that obesity is a leading factor or risk factor for the development of diabetes, especially type 2 diabetes. And so we try to really have a lot of attention paid to patients who have prediabetes and also are either overweight or obese to help manage their weight to prevent them from having that risk factor for the development of full-blown or type 2 diabetes. We also know that there are several reasons that people gain weight. I think as healthcare providers, it's really important not to have a stereotypical view as to someone who might be overweight or obese, because not only can lifestyle cause changes that lead to obesity, but also things like medical conditions. So thinking about patients who have decreased mobility due to musculoskeletal disease states or have to take things like chronic steroids for metabolic diseases as well. Those can easily cause patients to accumulate weight over a period of time and lead to either overweight states or obese states as well. And then we also know that by attacking, or I should say by addressing weight gain that is not wanted early on, we can cause significant improvement in not only lifestyle in terms of the patient's quality of life, but also glycemic control, blood pressure, and also cholesterol with their dyslipidemia being improved. And so as clinicians, we really should be paying attention to patients who are having significant increase in their weight that is not wanted, and patients who are having some of these secondary disease states that are linked to obesity and unwanted weight gain. So I wanted to spend some time talking about risk factors. One of the main risk factors as pharmacists that we should be considering are medications. And so I've listed some of the common medications that have been associated with weight gain. So when we think about things like corticosteroids, so our prednisone, methylprednisolone as options can, of course, with long-term use, cause accumulation of fat and also cause weight gain. In terms of our diabetes medications that we use for diabetes management, especially type 2 diabetes, we know medications like sulfonylureas are examples being glipizide, glimepiride, meglitinides as well, as also TZDs can also cause weight gain. And what is unique about the weight gain caused by TZDs like pioglitazone, it's really that water weight that can be accumulated in the body. And so we need to pay attention to when we are either prescribing or recommending options for treatment. If we have a patient that's already overweight or obese or has unwanted significant weight gain, then we should be more mindful about the medications that we are using for diabetes management, because some of them can also cause weight gain. Also, insulin, based on how it works with its mechanism of action, can also cause weight gain and accumulation of weight. So that's something that we need to pay attention to. Medications like anticonvulsants, antidepressants, antipsychotics can also cause weight gain. And then long-term use of certain beta blockers and oral contraceptives, especially the hormonal contraceptives, have also been associated with weight gain. So one of the interventions that we can make as clinical pharmacists is to recommend very appropriate alternatives to these medications if they exist, to help to reduce that risk factor of causing weight gain due to medications. So in terms of management of obesity in type 2 diabetes, I drew a lot of the content for this presentation from the 2022 Standards of Diabetes Care Guidelines from the American Diabetes Association. I work in primary care as a geriatric clinical pharmacist with a subspecialty and interest in diabetes management. And so I use this guideline pretty often, but we have other guidelines as well that are available for obesity and weight management. And so one of the key recommendations from the ADA guidelines is really to think about our assessment of weight. And so at a minimum, we should be assessing our patients' BMI annually or more frequently if we see them more frequently in our different healthcare institutions. Also paying attention to things like, of course, nutrition, physical activity, and behavioral therapy to help address weight gain. And that really is our first line approach when it comes to weight loss before we even think about pharmacotherapy or surgical interventions. In terms of our goal for weight loss, we're really aiming for at least a 5% or more weight loss goal within the first 3 months. If our patients are overweight or obese, as we know that this can significantly affect their glycemic control for the better and other weight-related comorbidities. If we are to recommend nutritional changes, we can recommend patients to have a caloric deficit when it comes to their diet or their nutrition meal plan, and really aiming for reducing that daily caloric intake by at least 500 calories. We know that about 3,500 calories will correspond to about 1 pound of weight gain. And so by being in a caloric deficit, that can also help with them achieving their weight loss goal. It's also really important that if we are to have a more strict, or I would say intense goal in terms of our nutritional content or diet plan, that we have that be supervised, because we do know there are several diets and nutritional kind of recommendations that might not be as healthy for patients. And so it's really important that that be supervised by medical practitioners. And then also for patients to achieve their short-term weight goal, it's really important that they have that physical activity in addition to the nutrition to help maintain that caloric deficit that will lead to the weight loss in the long term. There are several modalities when it comes to obesity management, but we also know that there are surgical options for patients, especially those who have class 2 and class 3 obesity that have tried either non-pharmacologic modalities or treatment modalities and have not been able to get success. And so based on the ADA guidelines here in the United States, we do recommend that patients can consider having bariatric surgery, of course, if they are class 3. So we're talking about those who have severe obesity of a BMI of 40 or higher. Also, if they have class 2, but they've tried other modalities before, they could be a good candidate for surgical management. And then lastly, even if they have class 1, if they've showed a history of failing previous therapies, they can also be recommended for treatment. Excuse me. So I want to now change our focus and our attention really to the medications that we use that have been approved for the management of obesity in patients with diabetes. I think it's important to always bring this, asterisk into play when we think about management of pharmacotherapy for obesity management. This is as adjunct or in addition to lifestyle changes, so that diet and physical activity and managing psychosocial issues are really the focus when it comes to obesity management. And we can use things like pharmacotherapy or surgical interventions to assist the patient in reaching their goals, but that should really be the focus. So when it comes to pharmacotherapy or medications that we use for obesity management, we have two major categories. One are those that fall under the short-term treatment algorithm, and those that we can use for longer term. So phentermine is the one medication that we have that can be used for weight loss, but really on a short-term basis. So it should not be used for more than usually 3 months. And then we have medications that can also be used to treat diabetes, or to manage diabetes, I should say, that have some weight loss potential. And we'll talk about those as well with GLP-1 agonists and SGLT2 inhibitors. And then we have other medications like orlistat, the combination of phentermine with topiramate, and naltrexone and bupropion that can be used and have been FDA approved in the United States for weight loss. It's also important to note that with these medications, if your patient is pregnant, for the most part, that is a contraindication for these weight loss medications. And it's really important that we wait until after safe delivery of the child before we consider weight loss medications and strategies. So starting with the first medication, phentermine, is something that we have available to help with weight loss. It is a sympathomimetic medication, and so it causes that release of norepinephrine that can help increase overall mood, can cause an increase in things like your heart rate and your blood pressure, but as an effect can also help reduce your appetite. And that's how it primarily works in the weight loss management algorithm. We have several versions of phentermine. We have capsules, we have tablets. I think it's just important to not only look at the cost, implications for your patient, but see what's also covered if they do have insurance. Something else to note for at least those that have to access phentermine in the United States, it is a controlled substance in Schedule 4. And so it's important for patients to realize that there are some addictive properties potential for this medication, which is why it's only recommended and approved for short-term use. In terms of dose adjustments, most times for hepatic insufficiency, we don't have any recommended by the manufacturers. But if your patient has stage 4, then we do have a maximum dose of usually 15 milligrams a day. And if they have end-stage renal disease, which is ESRD, then they should be avoided completely. As with most sympathomimetic medications, we have to worry about side effects, including increased blood pressure. So if someone already has uncontrolled hypertension, this is not a very good medication option for them. It can also cause increased heart rate, so palpitation and tachycardia, and cause tremors. In patients, it can also cause insomnia, which is why you want to take it early in the morning versus later on in the day. If patients are taking MAOIs or monoamine oxidase inhibitors for their depression, severe depression, you also want to avoid use of this medication due to the potential for a severe drug interaction. And then if they also have an angle closure glaucoma, they should also avoid phentermine. So this is really for those who want short-term assistance with their weight loss in addition to their lifestyle changes and do not have significant cardiovascular history or background or any medications or any medical conditions that can be affected by a sympathomimetic medication. When we think about our medications for the management of diabetes, we do have two major classes that come into play that have weight loss potential benefit. The first class are the GLP-1 agonists, and we actually have two medications in this class that are FDA approved specifically for weight loss. And so we know that GLP-1 agonists work well for helping to cause glucose-dependent insulin secretion as a way to work with diabetes management, but they also cause gastric emptying to be slowed, which is how they also assist with obesity or weight loss. And so there's several agents available. Some of the more common ones that you might see in practice are things like liraglutide or semaglutide, for example, being our newer agent that's been released. And we do have liraglutide and semaglutide as the two that are approved specifically for weight loss at higher doses. and that is Saxenda and Mjovi. With most GLP-1 agonist medications, we do have to worry about potential side effects. A lot of your patients might experience a lot of stomach or gastrointestinal discomfort or side effects like nausea, vomiting, diarrhea. We see that by starting at a lower dose and titrating up, that helps to mitigate some of these side effects. But we do have to kind of caution and inform our patients of this particular issue. And then for patients who have a history of either thyroid carcinoma or having severe renal impairment, we also want to avoid use in that population or caution in that population if they have renal impairment. And exenatide has a specific contraindication in patients who have stage 4 or less chronic kidney disease. Pancreatitis is also something that is important for you to consider as a potential side effect, or I should say complication, of GLP-1 agonist use in patients who either have a history or might develop that due to other risk factors. So in comparing the different GLP-1 agonists that we have on the market available and looking at the body weight reduction potential, we have found in studies that the semaglutide, the subcutaneous version, which is Ozempic, does have the most potential for weight loss compared to the other GLP-1 agonist. Second to that will be the oral semaglutide, which is Rybelsus. What we mostly see in practice based on just access and comfort with providers are things like liraglutide. And we do see that there is a significant amount of weight loss also with that and exenatide. And so depending on what your patient is able to afford, other comorbidities and their access to these medications, you can consider using either semaglutide or liraglutide at that higher prescription dose for weight loss. The other class of anti-diabetic medications that have potential for weight loss are SGLT2 inhibitors. So we know medications like canagliflozin, empagliflozin, dapagliflozin, and ertugliflozin can also, as one of the things we've seen in clinic or in clinical research, can cause weight loss. And in terms of the side effect of this medication, we do have to worry about dehydration due to all of the diuresis that happens with the glucosuria. We also have to worry about urinary tract infection potential when we're using these medications in our patients, and also some lipid abnormalities. For more severe side effects or concerns with SGLT2 inhibitors, please pay attention to patients who might be presenting with signs of diabetic ketoacidosis, DKA, but we also see them presenting with about normal or slightly elevated blood sugar readings. So we call that euglycemic DKA, and that is unique to SGLT2 inhibitors and a class-wide effect. We also have concerns for long-term use that might lead to bone fractures, and lastly, having those significant infections in genital areas or mycotic infections as well. So please keep that in mind when patients are on these medications for diabetes, that you're paying attention to these side effects, but that can potentially happen. And then in terms of a caution, due to that DKA risk, if any of your patients are going for surgical procedures, it is recommended for the medication to be held. And as we know with most inpatient admissions, usually insulin is the go-to medication for that diabetes and glycemic management until they're discharged. In comparing SGLT2 inhibitors to other classes like our DPP4 inhibitors, we do see that SGLT2 inhibitors have a weight loss or weight reduction potential. It is not as much as we have seen with our GLP-1 agonists, but still something to consider if you are trying to pick a medication for diabetes control in someone who is either overweight or obese and has access to these medications. The fact that they're also oral therapy tends to be one of the benefits of SGLT2 inhibitors when you compare them for weight loss in comparison to our GLP-1 agonists that are mostly injectable medications. The other class of medication that we use for weight loss that's been approved is orlistat. So this is something that is a reversible inhibitor of our lipase enzyme, and so it causes the absorption of dietary fats to be reduced by at least 30%. And so we have the over-the-counter dose of 60 milligrams and a prescription strength of 120 that is usually given before a meal is ingested. This medication, because of its effect with fat metabolism, it's really important to separate fat-soluble vitamins, which would be vitamin A, D, E, and K, from the administration of this medication by at least 2 hours. We don't have any recommendations given by the manufacturer for renal or hepatic impairment, but a lot of the side effects you're going to be seen in patients who are on this medication are GI related. And so because of the way it works, it can cause a lot of leaky stools or fatty stools, which can cause, sometimes we can see rectal incontinence. So patients might not be able to control their bowel movements for the first few weeks they start. A lot of flatulence, or patients who might have a lot of stomach discomfort or distress. So I always tell patients to start at the lower dose and work their way up as they're able to tolerate, and to take this medication when they know they're going to be home for a considerable amount of time to see how their body reacts to it versus having an accident outside. On a more severe note, when it comes to side effects, we have seen some patients develop cholelithiasis or gallbladder stones, also seen some patients have hepatotoxicity with liver issues, and then it can cause hypoglycemia in patients who have diabetes. So please pay attention to that as well if this is being recommended or prescribed. The other medication that is FDA approved or approved in the market for weight loss is a combination of phentermine, as we talked about earlier, and topiramate. And so we have this as an extended release formulation, a capsule that can also help with weight loss. We do have some renal considerations, and so the maximum dose is 15 milligrams of the combination if the patient is going to have stage 4 CKD, and we do recommend that you avoid using this in end-stage renal disease. For the most common side effects, we have similar side effects as phentermine, but we also see some patients present with paresthesia, so some abnormal movements. And then also they can have dry mouth with xerostomia. Very similar contraindications and considerations as with phentermine. So anyone who has a significant heart disease history should avoid this. History of drug abuse or addiction, because of that phentermine component, does have some addictive properties, or potential, I should say. You want to avoid that. And then if they have concomitant use of an MAOI or acute end closure glaucoma. The last medication we'll be talking about that is approved for weight loss, especially in the management of diabetes, is the combination of naltrexone and bupropion, which is available as an extended release formulation. And so we know naltrexone is an opioid antagonist, and bupropion is one of the antidepressants that we have available that can help prevent the reuptake of dopamine and norepinephrine. And we know that in studies, we've seen an effect on weight loss, mostly due to changes in brain function that causes a reduction in food intake. There are different, the formulation that's available usually is going to be the 8 milligram over the 90 milligram capsule. And so patients will start on a titration of 1 capsule in the morning and then increase up to 2 capsules twice a day as they tolerate over about a 4-week period. So please pay attention to that titration schedule to help with some of the side effects that can occur. When we think about our dose adjustments, usually, again, if someone has moderate to severe renal impairment, we would recommend stopping that 1 tablet twice a day instead of going to 2 tablets twice a day, and not recommending it for end-stage renal disease. And for those who have severe liver or hepatic impairment, 1 tablet in the morning is the maximum recommended dose by the manufacturer. In terms of side effects, pretty similar to what you would see with the phentermine topiramate combination. But what is really important to pay attention to is the naltrexone piece being an opioid antagonist. So if someone is taking an opioid medication for pain management, this is not an appropriate medication to give them, because it will cause them to have reduced pain control due to the antagonism of that opioid receptor. And so we do not recommend this for anyone who is taking chronic opioid therapy. Also paying attention to seizure risk. And so if someone has uncontrolled seizures, we want to be careful not to give this medication to them, because bupropion can affect seizure threshold, and worry about the risk of suicide ideation, especially in younger patients when it is first started. So you want to ensure that you have adequate follow-up. In terms of monitoring, we always recommend that, you might not see in terms of weight loss that immediate effect for the first couple of months, but it is still really important to monitor your patients for side effects at least monthly within the first 3 months of therapy initiation. So we pay attention to their cardiovascular health. We'll order labs if we have to look at the renal function and the hepatic function. And then making sure that the patient, again, is not having any kind of psychiatric side effects from these medications. And then once we see that they have had sufficient weight loss, usually 5% or more weight loss within the first 3 months, that is a good indication that whatever they're on, if it's not phentermine, can be continued for longer periods of time. If the patient was given phentermine, then unfortunately that is only good for 3 months based on the indication, and they would need to be switched to something else for weight loss potential. So in summary, it's important to pay attention to obesity when we have patients who have type 2 diabetes, especially in that population due to the linkage with insulin resistance, and then also that concern for cardiovascular disease. We do know that diet and lifestyle modifications are the first line recommendations when it comes to the management of obesity in patients with diabetes. And as a clinician who's practiced now for going to 10 years, I've seen a lot of success with patients who combine both pharmacotherapy with lifestyle changes to be able to achieve more than the typical 5 to 10 kilogram weight loss that we would usually see with these medications. It's also important to review the medication history for any kind of risk factors with medications that can also worsen weight gain. So paying attention to their diabetes regimen and offering options that are either weight neutral or weight loss potential versus the weight gains. So trying to avoid things like sulfonylureas, meglitinides, the TZD medications, and if they do not have, of course, in type 1 diabetes and need insulin, trying to also either avoid or reduce their insulin intake by using combination therapies. Our goal is really to achieve 5% or more weight loss within the first 3 months. And so if your patient is not able to achieve that within the first 3 months, that really is an indication that they have either failed therapy or might not be fully successful on the therapy you have chosen. So that would be a good time for you to reevaluate your strategy and potentially switch them to a different medication and also provide additional support for lifestyle changes. So with that, I'll be happy to answer any questions you have. And I've provided my email address as well in case you have any additional questions that you think of later on. I am more than happy to answer those via email as well. Thank you so much for your attention and time.
Hello, everyone. Can you hear me? Give me a thumbs up if you can. Hello, everyone. Can you hear me? Give me a thumbs up if you can. All right, good. All right, good. Yeah, thank you. So thank you, Dr. Tanda. Is Dr. Onyeme still on board? Okay. So Dr. Tanda will not be taking questions on the platform. She has provided her email address. So and when I mean on the platform, I mean, when I'm talking about the platform, I mean the WhatsApp platform. And so she has dedicated this next 30 minutes to answer questions about obesity management in diabetes. And so I encourage everyone to type their questions in the chat box so that she can respond to those. One thing that is certain is that some of the medications that were discussed may not be readily available in Nigeria. I have asked, and I do know that the Orlistat or Zenical is available. The GLPs are available. I did look for bupropion and naltrexone, and I didn't quite see it the last time I visited about a year ago. But some of you who are on the ground can let us know when if this medications are available and how to source them. I think that they will be available in bigger cities. I think when I looked in Enugu and I didn't find bupropion. One thing that is certain is, this idea of shaming or, when patients have diabetes and are obese or overweight, I think we should start looking at ways to help them. And there's absolutely nothing wrong with trying pharmacotherapy, because in the long run, you're trying to prevent a lot of things. It's no longer for aesthetics. It's now for health management, for management of the diabetes, to prevent that cardiovascular outcome. And so if there's anything that I have learned from listening to her talk, is the fact that patients should be offered medications if they meet criteria for obesity management, and also looking at the medications that they are already on. If they are taking that glipizide or glyburide, and we know that these are causing weight gain, maybe we should start thinking of having them use things that are weight neutral. Things like pioglitazone will increase the weight. Some beta blockers will also increase weight. So thinking about what is making them gain weight, it may be a good way to look at things instead of putting the blame on them for not losing weight. As far as I know, I think carvedilol is the one beta blocker that doesn't have as much weight gain properties. Metoprolol, propranolol, atenolol, all of them have weight gain properties. And I have seen success in just changing some of my patients from any of the beta blockers to carvedilol. So we'll look at the questions. Dr. Nyime, are you available to help us with the questions?
I have access to the questions, so I can just go ahead if you don't mind and respond to them. So thank you all so much for the engagement. I have some really good questions here. Before I go ahead and answer some of them, I think Dr. Nwezu mentioned a great point when it comes to management of obesity in Nigeria. I also tried to find some of these medications, but did not have access to the formulary to see what was available. And we also know that these medications are quite expensive. And so the first strategy for me as a pharmacist is always looking at that medication panel. What are the things I can make changes to that are cost effective to help reduce that weight gain potential? Even a simple switch from a glipizide or a glimepiride to maybe something like metformin might be enough to help either halt or start to cause some weight loss. We know that metformin is weight neutral, but comparing that to something that causes weight gain, it might be a good strategy if everything else checks out for that patient. So, even if they cannot, afford these injectable medications or things like SGLT2 inhibitors, just making that switch to something that's weight neutral will make all the difference usually for these patients. There was also a question about using this in patients without diabetes. So we can use medications like phentermine, orlistat, even the combination products without having diabetes on board as a disease state. I would caution the GLP-1 agonist. Now, we do have some data looking at the GLP-1 agonist in patients who do not have diabetes and still seeing that they're able to take that without hypoglycemia. But for the most part, because these are much higher doses needed to get to that weight loss potential, I'm always very mindful of monitoring blood sugar if someone does not have diabetes and has to take a GLP-1 agonist. Now, SGLT2 inhibitors are not approved specifically for weight loss, so we would not be using those medications in patients who do not have diabetes. But because one of the potential benefits in treating diabetes is weight loss, we can use SGLT2 inhibitors in patients who have diabetes. So I hope that answers that question about using these medications without having diabetes on board. And I would also be curious if any of the pharmacists can be so kind to share with us what medications you have access to in your practice for the management of obesity. So I received another question, and thank you very much for the question. It mentions about using medications like orlistat in patients without diabetes but are obese, and will that affect their GERD condition or not? For the patients that I've seen on orlistat and recommend them take orlistat, I've not really seen the GERD aggravation as much. What I have seen is if they have any kind of malabsorption condition, or if they have things like irritable bowel syndrome or any condition that affects their lower GI tract, that is something you want to be very careful about to try to avoid, because that can absolutely exacerbate or worsen those symptoms. But I've had a few patients who have a pretty active GERD and have been able to at least tolerate orlistat. And as mentioned before, these medications by themselves might give you upwards of up to 10 kilograms of weight loss at its best. But in combination with that lifestyle change, I actually had a patient who dropped about 50 pounds with using liraglutide at the higher dose, but she made some really significant lifestyle changes. And so as pharmacists, we can do a lot to also promote, healthy nutrition, increasing physical activity as tolerated, because that, with the combination of the medications, will give you the most impact for weight loss. And thank you all for your questions. Please feel free to still add some more questions to the comment chat.
There's a question on, it says, thank you for the presentation. Please, can you elaborate on the relationship between GLP-1 agonists and DKA?
So the DKA, and thank you for that question, the DKA relationship is mostly with SGLT2 inhibitors. And so we see with patients who have been taking either, especially canagliflozin, which is one of the earlier SGLT2 inhibitors, we were seeing that they would have the diabetic ketoacidosis, but their blood sugars were in the 200s and were not typically as high as we would see them. They might even be in the high 100s. And so there is, some hypothesis that all of that significant diuresis with SGLT2 inhibitors can trigger a diabetic ketoacidotic state, but that concern is mostly with our SGLT2 inhibitors. What we do see with GLP-1 agonists that you have to be very careful about is a potential to cause renal kind of irritation, especially if they already have reduced renal function. So part of that is because patients they feel full on this medication, so they might not be drinking as much water, and that can increase their risk for dehydration, which can trigger an acute kidney injury or worsening of their chronic kidney disease. And so if I have somebody who is the lower stage 3, stage 4, I'm very cautious about using these medications. And one of my biggest counseling points is usually hydration, making sure they stay very hydrated and trying to reduce any other medication that has nephrotoxic effect. That way we protect the kidneys as much as possible. So that is the one kind of, what's the word I'm looking for? Not as easily, thought of side effect that can happen with GLP-1 agonists. We all think about the stomach upset. We all think about the diarrhea, the pancreatitis, but also pay attention to the kidneys as well and do some monitoring in between.
Yeah, well done.
Yes, I definitely agree that affordability and availability not only in Nigeria, even here in the United States, we have access to the medication, but the cost is very prohibitive for a lot of our patients. And so I would love to use some of these newer diabetes medications, but I work in a geriatric clinic with patients with very fixed incomes. And so I have to rely more on making those smaller changes by switching their medications to things that have less weight gain potential. And then in the short term, we've used phentermine for some of our patients that do not have cardiovascular history. But across the board, medication cost is an absolute issue. And we only, we hope that things get better in the future, but that is very prohibitive.
The other thing I was just thinking about is the thought in our last lectures, we had learned that diabetes in Nigeria is more prevalent in the affluent Nigerian population. So, the people who are, diagnosed, usually Southeast, all workers. And so they're more affluent. I think part of what we're hoping to achieve in presenting this to you is to let you know that there are options to manage obesity. That is, when you're thinking about diabetes, that while you're thinking about glycemic control, it's important to also think about obesogenic medication, making sure they are not on obesogenic medication and giving them medications that will help with weight loss. And so if you're treating somebody who is more affluent, being aware of these available and what they could use and the potential benefits of these medications that are seemingly expensive,
That is a great point. I think even thinking outside of just the diabetes management, steroids are one of the medications that I see because I also have a significant kind of practice with our musculoskeletal team, and a lot of rheumatoid arthritis, lupus, things like that. We use long-term steroids for RA, and steroids long-term, I've seen patients gain so much weight. And so whenever I see somebody on long-term steroids and their disease state is somewhat controlled, I always attack, that particular steroid medication and say, what are we doing about that? Let me talk to your rheumatologist. Is there a way to either start to decrease that dose or to, try to transition you to some other maintenance medications so that we can eventually get you off of steroids? Because not only for weight gain potential is steroids quite complicated in management, but it can wreak havoc on several, organs for long-term use. So also think about things like that. Antipsychotics are a bit tricky because it's class-wide and patients who are typically on them need them. But things like steroids that can be, titrated off, oral contraceptives, start to think about the full medication list and what are some changes you can make.
That's fine. Get back to what else?
And I would say, since I don't see any more questions, my other parting advice is really pay attention to how you're addressing patients if they are, struggling with obesity, or even how to start the conversation. Like Dr. Winzu mentioned earlier, try to avoid that, accusatory language or any shame associated with that is not helpful at all as a strategy. And there's several reasons why people gain weight that, might not be just lifestyle changes or choices. So really trying to encourage them, really using positive language, trying your best to, provide these resources for lifestyle changes for physical activity without, using any kind of accusatory language or language that might be perceived as negative or kind of shaming, I think has been very helpful in my practice. And so please keep that in mind. Those little words we say can go a long way in having our patients trust us and open up to us and our recommendations, or have them not want to listen, because we can prescribe and we can recommend all we want, but if they don't take it, it's not going to work. So really try to have that, collaborative language and also relationship with your patients to help them.
All right, everyone. It looks like there are no more questions coming. And even though Dr. Tanda will not be available on the WhatsApp platform, feel free to send her an email if you want a direct answer from her. You can also post your questions for discussion by the rest of the crew. We can make our contributions and share our experiences with you all. I want to thank Dr. Tanda for bringing out this time to speak to us on this topic. I hope it has at least opened our eyes and made us more aware of what is possible. So thank you so much. And we promised you guys that we will always end by the hour on the dot. It is 59 minutes into the hour. So I think it's time for us to say thank you and then good night to everyone. And please send your emails. We'll post the slides and the whole presentation on the platform. And you can also bring up your questions on the platform for us to have a discussion on. I think the whole idea of having that WhatsApp platform is to share our experiences and learn from each other. So feel free to do that. Thank you, everyone, and good night.
Thank you for having me. Have a great evening.